Hello everyone, welcome to my YouTube channel. My name is Amanda, and if you're new here, I am a new grad nurse in a level 3 NICU. I am in a nurse residency program that started back in August 2025, so I feel like I'm at a pretty good state right now where I'm comfortable off of orientation and I feel ready to share with you guys what it looks like for my 12-hour shift. So first, like I said, I am in a level 3 NICU, and I will just share with you guys that there are 4 levels to a NICU. Level 1 being kind of like a well baby nursery, a level 2 where I think they see babies that are born around 35 weeks and greater, and they may need like tube feeding, some respiratory support, but it's kind of more of like a feeder grower type of NICU. And then I work in a level 3, so we see babies from micro preemies that are born at 23 weeks gestation up to they may be born at like 41 weeks. So very wide range of intensive care, and today I'm going to explain all about that with you guys. And then a level 4 is going to be the highest level of care. It's going to be more long-term care, everything that a level 3 does, but the baby might need some surgeries like cardiac surgery, GI surgery. They do ECMO, so it's just more intensive and prolonged care in a level 4. I do have a video posted, I think I did it back in summer or like the early beginning stages of my residency program, where I discussed how I got my job as a NICU nurse being a new grad. So go back and check that out if you want to see or hear my advice on how to get into the NICU as a new grad. So in the beginning months of my residency program, I had 5.5 months of orientation where I had my primary preceptor for day and night shift, and then I had some other preceptors, but I mainly had primary preceptors that I was working alongside, learning from them all the hands-on skills with the babies, and they were truly my stepping stone of education to being a NICU nurse. I'm so grateful for them. And alongside that, I had like 2 to 3 intensive months of like NICU education, because in nursing school you don't learn much about the NICU. So there's a lot of NICU things that are taught during the orientation phase of being a new grad resident in the NICU. So that felt like being in school again, because I had like classes that were through Teams meetings, and then I had in-person skills. There were some like tests that I had to do, but nothing to where I was like graded and like had to pass. It was all strictly educational purposes. We do have an educator for the unit, so if I feel like I'm struggling with anything at any time, I can request a meeting with her and we can go to the skills lab. So you don't have to do any extra additional programs to be a NICU nurse. All of it was taught during my NICU orientation. So I came off of orientation the end of this January 2026. So I've been on my own now for a few months. And yeah, I wanted to explain exactly what my 12-hour shift looks like. I'm going to be talking about the assessments, interacting with patients, how our interdisciplinary team works, and sort of just like the flow of the shift, and also a little comparison to night shift, because I do work both right now. I'm rotating every other month for the rest of my residency. So that's pretty nice because I get to like focus on a balance between day and night shift. But once I finish the residency program, I will be on nights. So like I said, in a level 3 NICU, we see babies born at 23 weeks gestation up to 41 weeks gestation. So I will just discuss like an overview of what the assessment looks like and how I work through our care times. Obviously, if they're born very early at 23 weeks, that setup of care and just setting up centralized and IV fluids compared to a baby that's born at like 32 or 36 weeks, it's going to be very different, and I'll probably make a lot more videos discussing that, but I want to give you an overview of what my day looks like in case you are considering being a NICU nurse, and let's get started. So NICU units can be very different depending on the hospitals, but generally they are pretty much the same when it comes to caring for NICU babies. So on my unit, we have assignments that are just 2 babies. Some cases we'll have a 3 baby assignment if they're like feeder growers, but they're mostly stable. Some of them are prepping to be discharged in the next coming weeks. And then sometimes we'll have like a 1-to-1 assignment if the baby is born very early, if they're intubated, if they have a lot of central line IV fluids going on, if they are having a lot of respiratory and cardiac events, they just need a lot more close monitoring. Mostly we'll have 2 baby assignments, sometimes 3. And at the start of the shift, we meet with the nurse to give report and get any updates and just all the information on the baby. So I will talk you guys through how we give report on my unit. So we have a report sheet, and pretty much we start with maybe like the day and time the baby was born, their gestational age. We also say the corrected age because the baby could be born at 30 weeks and 4 days, but today they are 30 weeks and 7 days. So we always record the gestational age, the corrected age. We give their birth weight, we give their updated birth weights. We always check the baby's weights every single night. That way, in the next morning, the nurses and the care plan team will be able to make any adjustments based on the baby's new weight. After that, we move on to the mom's history. So what was going on with the pregnancy? How was the baby delivered? Was there any delivery complications, any pregnancy complications? Was the mom taking any medications? If she's had any previous pregnancies, does she have any live children? And how the delivery went. And then after that, we move on to the baby's assessment right after delivery. So what was the baby's APGARs? Was the baby resuscitated at all? What kind of respiratory support was the baby put on? When they were transferred to the NICU, what respiratory did we start them on? Did we get them stable? Pretty much note-taking how they transitioned into the NICU. If they've been in the NICU for a few days or a few weeks, we tend to like kind of summarize and say they've had a bunch of respiratory changes. We'll just give the specific dates, like this baby was on CPAP, and then on this day, we wean them down to nasal cannula. If they were given any antibiotics, did they require any dextrose for like hypoglycemia? Pretty much any updates after the delivery. And then the rest of our report is pretty much like a head-to-toe assessment. So we discuss if the baby has had any head ultrasounds, if the baby has had any ROP exams, which is an eye exam that we do for premature babies. I think in our unit we do them if they were born before 32 weeks, but ROT stands for retinopathy of premature babies. So if they've had any head ultrasounds, if they have had any ROP exams, also if they were born before a certain chronological age, which is on our unit, this standard like gold number is pretty much 32 weeks for a lot of things, but we keep them on what's called an IVH bundle for the first 3 days of their lives, so 72 hours. IVH stands for intraventricular hemorrhage in the brain. So during those first 72 hours, we are very, very careful with how we are moving them around. We don't lift their legs above the level of their heart too much, especially when changing diapers. We keep their head midline with their body, and pretty much this is limiting the risk of developing any hemorrhage in the brain because they are born early and they can easily develop hemorrhages. Next, we move on to anything cardiac related. Does the baby have a murmur? Has the baby had any echo tests yet? Do they have like a PDA or PFO, which is very common with babies that are born premature, especially if they were born via C-section, because after we're born, when we take that first deep breath is pretty much helps our heart and lungs transition. After cardiac is when we move on to respiratory. So what kind of respiratory support are they requiring right now? Some of those might mean that the baby's intubated and is on a ventilator. We have a bubble CPAP, which helps expand the baby's lungs. So sometimes you'll see babies with the mask on their nose, or what we call prongs. So it goes into both nostrils, and that supplies like humidified oxygen to keep their lungs expanded. Or we have a high flow nasal cannula, which kind of looks like a thicker, heavy duty nasal cannula that just provides more flow, up to, usually we'll do like 1 to 4 liters of that. And then the last oxygen therapy would be a regular traditional nasal cannula. Along with respiratory, we report if they've had any chest x-rays. A lot of times we'll do an abdomen included in the chest x-ray, mostly to check like any line placements, and of course to see how the lungs look, if they're hyperinflated, is there any atelectasis, is there a pneumothorax? So depending on the baby's gestational age and how they are transitioning, sometimes we get a chest x-ray multiple times in the day. We also let the nurse know if the baby has had any blood transfusions, platelet transfusions. Some babies that have PDAs for an extensive time, they are treated with Tylenol to help close up the PDA. So then we'll discuss any treatments that the baby has had. Then we will talk about if the baby has any central lines. So that could be a PICC line, it could be an umbilical artery catheter, it could be an umbilical vein catheter. We have had a baby once that had a Baroviac line. We will report all the IV fluids that the baby has and the rate that it's going per hour. If the baby has had any boluses. And then a big thing with central lines is we discuss how the central line is placed. So picture a long catheter. So let's say it's like 20 centimeters long. We report how much of that catheter is in the baby in centimeters, and then externally. And then we go to the bedside to physically check the baby and make sure that it is in place and intact and not draining. The dressing is transparent and there's no signs of infection. Some fluids that are very common in the NICU is TPN and SMOF. So TPN is essentially vitamins, minerals, basically all the nutrients that we can give to the baby if they are not drinking milk yet. SMOF is lipids, in other terms it's fats, and it's pretty much like DHA, like all the healthy fats that we would want, that the baby needs if they're not drinking milk yet. Some other fluids that are common are like D5, D10, D20, sometimes D25, which is sugar that we often use to treat hypoglycemia. After we discuss the IV fluids and lines, we move on to feedings. So some babies can be NPO, meaning they're not taking any milk just yet, and that's why they have the TPN and SMOF. But for babies that are taking milk, in our terms, we'll say like the baby is feeding EBM and DBM. So at the hospital I work at, we have a donor breast milk program. So if the mom isn't making her own breast milk quite yet, they'll sign consent that we can give donor breast milk. And the donor breast milk is essentially pasteurized breast milk. So the moms that donate their milk, it's tested and it's cleaned and it's completely safe for the babies. So the babies will be drinking either express breast milk from their own mother or donor breast milk. And then we also have formula, and then we have formula additives. And those are like a whole nother topic to discuss on adding formula additives for babies. But especially for premature babies, they will need like higher calories or fats, and the whole neonatal nutritionist that reviews the baby's weights and discuss with the doctor like what the baby requires. So that's how the feedings work. And We also monitor closely the volume that the baby is getting, and then if they're drinking out of a bottle, which is called PO feeds, us as the nurse feeding them, we're going to evaluate how they're feeding, how they're tolerating the milk. And then we also have speech and language pathologists that do their own assessments with babies and assess their readiness and how they're latching, making sure that they're not aspirating. And they can also evaluate if like our bottles and nipples aren't benefiting the baby. So sometimes they'll essentially prescribe the baby a Dr. Brown's bottle, and just discuss further in detail with the parents on bottle feeding and breastfeeding with their baby. We also let them know if the baby has a feeding tube, so this could be an OG or an NG tube. And we on the feeding tubes, it has little numbers on it. So sometimes you'll see like a baby has like a piece of tape here with the feeding tube going to their nose or their mouth. So that number is pretty critical because we want to make sure that it is in place. Often the babies can rip out the feeding tube themselves, or if they're on like a bubble CPAP and they have a lot of secretions, it can slide out easily. So it's a huge part of our assessment to auscultate and aspirate and make sure that the feeding tube is in the right place. Then we move on and discuss if the baby is voiding and stooling, anything that's like GI or G related, and then if the baby has had any labs or if the oncoming nurse will have to do any labs. And before leaving, we go through all the orders together and the medications. And then like I said, if the baby has like an IV or a central line, then we'll go to the bedside and make sure that the IV or central line is patent and there's no draining or signs of infection.